Hello everyone, a warm welcome to all of you in this particular lecture where we will be discussing about the endotracheal intubation. I hope some of you might have heard the term and some of you might not have heard the term yet. Now in this particular lecture we will be discussing what that particular term means, the endotracheal intubation, what is this process and what can be the possible indications in which we need to do this endotracheal intubation, what are the equipments that will be required at the time of intubation, what is the technique that we use at the time of intubation. We will be discussing about how we confirm the tube is in proper place. We will be discussing how ventilation is done through that particular tube, and also we will be discussing about the complications of endotracheal intubation and what the process of extubation means. So when we go to the term endotracheal intubation, in the first particular term there is endo and tracheal. In this particular term, the endo means inside, tracheal represents the trachea, intubation means a process in which a tube is inserted. So there are actually two terms, one is intubation, another one is extubation. In case of intubation, a tube is inserted, and in case of extubation, a tube is taken out. So when we talk about the endotracheal intubation, it is a process where a tube is inserted into the trachea. Now this particular tube is not like any other common tube. It is a special tube which we know as the endotracheal tube or the ET tube. So that particular tube is inserted into the trachea, and this tube is actually used for the purpose of ventilation, and we can ventilate the patient by this particular tube once it is inserted into the trachea. So first of all, we all should know what are the indications or what are the reasons because of which we need to intubate a patient. So firstly, whenever we need to secure the airway of a patient at that particular point of time, we need to insert the endotracheal tube. Whenever we need to give supply of oxygen to the patient and the patient is not able to maintain the oxygen saturation on the mask, so at that particular point of time we intubate the patient and give oxygen supply by this particular tube. And whenever we give general anesthesia to the patient, at that particular point the patient is not able to ventilate or inhale or exhale by himself or herself, and at that particular point of time we also need to intubate the patient and give artificial ventilation. Also at the time of cardiopulmonary resuscitation, which is a life-saving process that is done at the time whenever the patient is in cardiac arrest. So at that time the patient is not able to breathe, so by that particular method, the intubation method, we can actually provide artificial ventilation to the patient. And also whenever we require ventilatory therapy or ventilation therapy in case of ICU, if the patient is admitted in the ICU for a long term and is not able to breathe in or inhale or exhale, so at that particular point we need to intubate that particular patient. So now we will be discussing about the equipments that are required at the time of endotracheal intubation. Firstly, we will require an endotracheal tube. The tube is made up of PVC. Initially we were having red rubber tubes as well, but nowadays we are having PVC tubes. The PVC tubes are single-use tube, while as the red rubber were multi-use tubes. So we can say in case of this tube there are various sizes that are available, and they are according to the age group. For example, if the patient is a neonate of the age of 0 to 1 years, then in that case we'll be using 2.5 to 3.5 mm tubes, and they will be plain tubes. Because when we talk about the different types of tube, there is plain tube and there is cuffed tube. The plain tube is not having any type of cuff that can be inflated, while as in case of cuffed tube there is a cuff that is inflated inside the trachea. And in case if the age is 1 to 3 years, then we use 4 to 5 mm, and in case if the age is 4 to 6 years, then we use 5 to 6 mm. In case if the age is 6 to 10 years, then we use 6 to 7 mm. And in case of adults, when the adult female is there, we normally use 7 to 8 mm, and in case of an adult male we can use 8 to 9 mm. Commonly for adult females we use 7 to 7.5, while as in case of adult males we use 8 and 8.5 mm. Also, along with the endotracheal tube, we require laryngoscope, we require Magel's forceps, we require stethoscope, we require syringe, we require the source of ventilation, and also we require the suction. Also, we require the suction apparatus. So here in this particular image, you can see different sizes of the endotracheal tube and also some different designs that are available. So we can use any of them according to the age group. In this image, you can see the laryngoscopes. This is the laryngoscope which is used for visualizing the vocal cords, because when we need to intubate, we have to actually insert the tube through the vocal cords, and for visualizing those vocal cords, we require this special device which is having a light source and a blade. So that blade actually displaces the tongue, and the light source provides enough light to visualize the vocal cords. This is the Magel forceps. This forceps actually is used for guiding the endotracheal tube towards trachea. That is why this forceps is also known as intubation forceps. Now we also require syringe as well, because this syringe is connected to the inflating port through which we can inflate the cuff. And also we require the suction apparatus. This suction apparatus is used for suctioning any type of secretions that will be present on the throat. Now at the time of intubation, we actually require to give a particular position to the patient. That position is known as sniffing position. In that particular position, we need a pillow, and that pillow mostly needs to support the neck and the head of the patient. And we actually need to place the patient in such a way that there is extension of the atlanto-occipital joint. The atlanto-occipital joint is actually the joint between the skull and the first vertebra. So that is the atlanto-occipital joint, and we need to actually be able to extend and flex the neck. So that is how the position should be. And in this particular image, you can see that there are three axes. One is the laryngeal axis, second one is the pharyngeal axis, and third one is the oral axis. So whenever we need to intubate, these should be slightly aligned. Like you can see in case of a B image, the oral axis is not properly aligned with the pharyngeal and the laryngeal axis. But in case of image C, you can see that the laryngeal axis, the pharyngeal axis, and the oral axis are slightly aligned in the same direction. So that is the position in which we will be able to visualize the vocal cords more properly. So we hold the laryngoscope after giving the position, and we hold the laryngoscope with our left hand, irrespective of the dominant hand. Doesn't matter if you are lefty or righty, we have to handle it with the left hand. We open the mouth with our right hand using our index finger and our thumb. And then we introduce this laryngoscope from the right side of the mouth, that is slightly towards the right side of our body. And then once we go down, we shift the laryngoscope blade slightly towards the left inside the mouth, so that the tongue gets shifted towards the left side. And once we go down, we will reach the epiglottis. And once, if there are two situations, either we can lift the epiglottis or we can displace it. So once we displace or lift the epiglottis, we will be able to wash the vocal cords. So this is the thing how we actually insert the laryngoscope. In case of laryngoscope, there are mostly two types of blades. One is curved blade and second one is straight blade. Curved blade is mostly used in case of adults, while straight blade is used in case of children. And once we are inside and we are able to visualize the vocal cords, we will take the endotracheal tube with our right hand and we will introduce it under the direct vision into the trachea through the vocal cords. And once we are inside the trachea, we firstly confirm that the tube is in proper place and both the lungs are getting ventilated. And once we are sure, we inflate the cuff of the tube, and then after that we will actually fix the tube. In certain cases, if we are not able to see the epiglottis and if we are not able to visualize the vocal cords, in that particular case we can use video laryngoscopes, which are actually advanced laryngoscopes nowadays, having a small monitor on it, and through that we can indirectly see the vocal cords on the particular screen that we are having, and by that we will be able to ventilate, you can say we will be able to place the tube properly, and there will be no difficulty in case of if the patient is having a difficult intubation, or if the patient is having a difficult airway and we are not able to visualize the vocal cords properly. In that particular case, we can use the video laryngoscope. So once we are inside the trachea and we have confirmed that the tube is in proper place, we connect the tube to the source. After that, we can actually ventilate the patient. For the purpose of confirmation, we can use certain methods like by auscultation. It is a process in which we use a stethoscope to hear the breath sounds, and also we can confirm the tube placement by chest expansion. If the lungs are being ventilated, then our chest will expand in size, so we can actually watch for that as well. Also, the bag by which we are ventilating the patient, there will be movement in that bag as well. And also we are having a type of a monitoring method which we call as capnography, in which we actually monitor the expired carbon dioxide, so we can actually check that as well. If there is a graph which is showing that the carbon dioxide is being expired, that means we are inside the trachea. And once all the particular confirmations are done and we are sure that the tube is in its proper place, then at that particular point of time we fix the tube with adhesive, or we can use any other methods. Mostly we use the adhesive for fixing the tube. Now once the tube is fixed and the tube is in its proper place and we have confirmed the tube placement, we can ventilate the patient. Now for ventilation purpose, we can use multiple methods, like we can use EMBU bag, which is artificial manual breathing unit bag, which is actually a device by which we can ventilate a patient. And also we can use anesthesia machine as well for the purpose of ventilation, and we can use ventilator as well. So there can be certain side effects that can be there, or we can say at the time of intubation there can be some reactions which we call as intubation process reactions, or we can say intubation reaction as well. So in that case there can be tachycardia, which is a condition where there is increased heart rate. There can be increase in the blood pressure as well. There can be increase in the secretions, especially in case of the secretions that come to the throat. There can be laryngospasm. It is a possible, we can say, reaction which can happen, and it's dangerous because in this case the vocal cords actually get closed and the patient is not able to open the vocal cords, and also we are not actually able to pass the vocal cords as well. So this is a possible complication or a reaction which can happen. And also there can be bronchospasm. In this case the bronchial tree actually gets into spasm, and the bronchial tree actually constricts, and by which the process of ventilation is not effective, and the patient is not able to get the patient is not able to get enough supply of oxygen that the patient actually requires. Now, along with the possible side effects or the reactions, there can be complications of endotracheal intubation as well. The most serious complication among the complications is the esophageal intubation. In this particular case, the tube is inserted and we feel like we have inserted the tube into the trachea, but the tube is actually placed inside the esophagus. So this is a possible, you can say, serious complication that can happen, and in this case the patient is not being ventilated because the air that we are giving is actually going into the stomach. Second possible complication that is there is the endobronchial intubation. In this case we are actually inserting the tube into the trachea, but we are pushing it forward so it goes to either of the bronchi. So it can go to right main bronchus or the left main bronchus. Possibly, mostly it goes to the right main bronchus. The reason is that the right main bronchus is more wider and also it is slightly straight. And in case when we talk about the another complication, that is the trauma on the lips. So the patient, once we are actually intubating the patient and we use the laryngoscope, by that laryngoscope there can be trauma with our lips and our teeth. So that is also a possible complication. There can be bleeding, which is mostly because of the tip of the laryngoscope, because laryngoscope is metallic thing and that can actually cause trauma. And also there can be leak, which will be actually when we intubate the patient and the tube is inside the trachea. So in that case, when we inflate the tube, the cuff is not actually covering the trachea properly. There can be tracheitis. Tracheitis is a condition where there is inflammation of the trachea. This will be because of the continuous pressure of the endotracheal tube on the trachea. Also there can be cough, which will, we can say when the patient is actually having the tube inside. So the patient can actually sometimes have irritation because of the receptors and the patient can actually cough sometimes, which is a possible complication. There can be sore throat. This mostly happens once we take out the, you can say, tube, and after that post intubation, so once post extubation, we can say, once the tube has been taken out, the patient feels sore throat. So that is also a possible complication. And also there can be barotrauma to the lungs. Barotrauma is a trauma which is because of pressure. So in this case, sometimes there can be high pressure delivery of the gas into the lungs, and that can lead to barotrauma. And when we talk about the positive effects of the intubation, it can increase the oxygen supply to the patient. It can be used to give general anesthesia, because in case of general anesthesia we are having two particular methods. One method is when we give through the veins, so that will be intravenous induction, and when we give it through the endotracheal tube, that will be inhalational induction. In that particular method we use inhalational agents like isoflurane, sevoflurane, desflurane, etc., and once they are delivered to the lungs, they get actually diffused into our blood and they can actually cause anesthesia. And also intubation can improve the exhalation of carbon dioxide. The carbon dioxide can be exhaled, you can say, in a better way. So that is also a good effect of intubation. And once the process of intubation is done, we can ventilate the patient and we can actually use it for the purpose of ventilation throughout the duration whenever it is required. And once it is not required, the tube needs to be taken out. So for extubation, firstly we need to actually use the suction apparatus, by which we can suction out all the particular secretions that are collected at the throat. And then after that we can do laryngoscopy. We can insert the laryngoscope and visualize the area, and we can actually blunt the reflexes as well. We can continuously monitor the SpO2. Adequate respiration is given firstly. Level of consciousness of the patient is checked, and once all the things are good, then at that time we can deflate the cuff of the tube and we can take it out slightly, and after taking it out we have to do suctioning at throat so that the secretions that will be present there, they will not go into the lungs. So now we will give the overview of that particular process that we have discussed. Firstly, we have to check all the equipments are required and they are functional. We can check the cuff as well. Firstly, we need to pre-oxygenate the patient. This will actually create a reservoir of gas inside the lungs, so that the time which is used for intubation, in that particular time that oxygen will be used. And then we open the mouth, we insert the laryngoscope after giving proper position to the patient, and once the laryngoscope is inserted, we actually check and watch for the vocal cords. So firstly we insert it slightly rightwards and then go slightly towards the left side, and this is how the laryngoscope will work. It will actually suppress the tongue, and we will be able to visualize the vocal cords properly. Like in this particular image, you can see we are able to visualize the vocal cords in the yellow color, and then once we are able to visualize the vocal cords, we insert the endotracheal tube through those vocal cords into the trachea. and once the tube is inside the trachea, we actually position the tube properly as the age of the particular patient will require. So for example, in case of adult males we have to go for 22 centimeters. In case of adult females we have to go for 20 centimeters. After that we take out the laryngoscope and we inflate the cuff, and once the cuff is inflated, then after that we can actually connect the patient to the embu bag or the ventilator or the anesthesia machine, and we can ventilate the patient, and we can confirm that the tube is in we need to confirm that the tube is in proper position. We need to check at different places whether all the areas of the lungs are being ventilated properly. If one side of the lung is ventilated and the another side is not ventilated, then we need to deflate the cuff, and at that point we need to actually take out the tube slightly back and then inflate it. After giving the proper idea of the whole process, we need to slightly discuss about failed or difficult intubation. Now, difficult intubation is that condition where the insertion of the tube is not easy. In this case, the opening of the mouth can be restricted, or the vocal cords can be slightly anterior, that is towards the front side, and in that case we will not be able to check the vocal cords properly, and we will not be able to see the vocal cords properly. And also sometimes there can be burns on the neck, and by that we will not be able to give proper position to the particular patient. And in that case we will actually be facing difficulties while intubating the patient, and sometimes if we try to intubate the patient it might fail and we will not be successfully able to insert the tube into the vocal cords. And once we face these conditions, we can use certain things, like we can use fiber optic laryngoscope, and fiber optic intubation can be done by that thing, and that will be, you can say, it's a flexible type of laryngoscope which will be guiding our endotracheal tube through different curves. And also we can do awake intubation. In this case we are not using muscle relaxants or sedations. We actually give pressure on the cricoid cartilage and then we intubate the patient. Also we can use retrograde intubation. In case of retrograde intubation, it is a special type of intubation. I will be showing you what retrograde intubation is. Actually in that case we have to insert a thin wire through here, and it comes out through the mouth, and then we actually glide the tube over that and it goes into the trachea. And also we can use supraglottic devices as well, like our LMAs. So this is the LMA which we can use. In this case it doesn't go beyond the epiglottis or below the vocal cords, it remains above the epiglottis, and by this case the chances of failed intubation will be actually rectified because this is not actually inserted into the trachea. So in this case we don't require any particular confirmation, it will be properly. So now I will be showing you what retrograde intubation is. So if you see, there is a patient, and firstly we actually use the needle, and this needle is inserted in the cricothyroid membrane. Through this needle we insert a guide wire. That guide wire goes through that particular needle and it comes out through the mouth, like you can see in this particular video. We are inserting the guide wire, and once we have inserted the guide wire, it will come out through the mouth or the nose. Mostly we use nose, and then after that, once it is done, we actually use endotracheal tube. That endotracheal tube is glided over that particular guide wire and it is inserted into the trachea by this particular guide wire. You can see that the tube is going through the nose, and once it goes in, then after that we can take the guide wire out, and once the guide wire is out, we are inside the trachea. So this is how the retrograde intubation is done. After that we inflate the tube and it is done.